Hello, this is Hadi Lichaa, interventional cardiologist, describing the perforated balloon technique for coronary no reflow, which is one of the most difficult things for us interventional cardiologists to deal with most of the time in the middle of a high-risk STEMI. So obviously, injecting vasodilators from the coronary guide usually ends up in either the aorta or in the alternative vessel that is patent rather than the occluded vessel. So it's very important to deliver the drugs distally. Of course, dual lumen microcatheters can be used in this case, or even thrombectomy, regular thrombectomy catheters, but those are usually limited in their deliverability through tortuosity until the Sasuke catheter was available on the market, and that's obviously highly recommended, but it's expensive and not available in all labs. So this technique provides an alternative for people who don't have that on the shelf, and it's much cheaper way to deliver drugs distally. Pretty simple. So a 25 gauge syringe is taken, the one that's used for local anesthesia, and you perforate the smallest balloon you have on the shelf, either a 1.0 or a 1.25 millimeter by 6 millimeter most of the time. And it's very important to avoid air embolization with this technique, so connect it to the inflator and inflate. That would hopefully get the air bubbles out of the system. And obviously this technique is very important because it provides the advantage of maintaining wire access rather than removing the wire and injecting this through an over-the-wire balloon. So that's the major advantage, especially in very tough to cross anatomies, or if the operator suspects a dissection and does not want to get rid of the wire if IVUS is not available. So that's the first step. Second step is to actually push on the balloon to minimize its crossing profile, since you cannot go negative on the inflator to minimize the risk of air embolism. You flatten the balloon as much as you can, and you deliver it all the way down to the distal bed, as distal as you can. And then at this point, you connect to the inflator and go negative at this point. First, you're going to see air bubbles, then you're going to see a straight column of blood coming up. Whenever you have a column of blood without any air bubbles, this is the time when you disconnect from the inflator and you connect to your syringe that has the vasodilators. One of the technical tips about that is not only mix with saline, but also with contrast that allows you to visualize the delivery of the vasodilators in the distal bed and how fast they're actually being cleared out. Nicardipine and nitroprusside could be picked in patients who are hypertensive or with decent blood pressure. Adenosine, usually in the non-right coronary artery system, to minimize conduction abnormalities unless you have a transvenous pacing catheter. Epinephrine is great for shocky patients with severe hypotension unless they have refractory ventricular tachycardia. And this is an effective, safe, and a cheap way to deliver the drugs distally. Most of the time, you're going to get TIMI-3 flow with that, obviously with adequate antiplatelet and anticoagulation therapy, but it is highly recommended. I hope you enjoyed this, and thank you for your attention.